Thank you for joining this webinar. I may invite you to introduce yourself in the chat if you'd like to. Be reminded that you need to select everyone in order to chat to everyone on the webinar. You could add your name, your organization, and the work that you're doing in the country where you are. It may be morning, afternoon, or evening where you are. I am Marianne Bakermans-Kranenburg. I'm involved in the Evidence for Impact Working Group. Apart from that, I am affiliated with ISPA Lisbon, and I've been studying caregiving and child development for the past 3 decades, both in institutional settings, foster and adoption families, and biological families. This webinar of today is organized in the context of the Evidence for Impact Working Group within the Transforming Children's Care Global Collaborative Platform. And today I'm happy that we have 3 very special guests contributing, whom I am going to introduce in a minute, but first some housekeeping. This session is recorded, as you probably already realized. That helps us in sending it afterwards to each of you so that you can review it again. Attendees won't be able to speak during the presentations or during the discussion, but you can use the chat and Q&A function for questions, where you can also vote for other participants' questions there, so that we can make sure that the areas people are most interested in are definitely discussed during the discussion session. The setup for today is that we will start with a presentation on the well-known Bucharest Early Intervention Project, or BEIP, and the new study that the authors started in Brazil. Each of the PIs, Chuck Nelson, Nathan Fox, and Charlie Zena, will present for about 10 minutes, followed by questions and answers. Given the size of the audience today, the question will, as I said, be generated with the Q&A function that you see on the bottom of your screen. Let me now briefly introduce the presenters. All 3 of them have been showered with prizes and awards, most recently Chuck Nelson last week on the conference of the Society for Research in Child Development, where he received a distinguished scientific contribution to child development. And apart from the incredibly rich work that each of them has done in their own fields of expertise, they embarked together some 20 years ago on a project setting up a foster care system in Romania where no such system existed. Moreover, they studied the effects on children of the transition from institutional care to family-based care. And the study is unique in that it is the only one that allows for causal conclusions of these effects, because they let chance decide about the children who were placed in foster families and those who remained in the institution. I truly recommend their book, Romania's Abandoned Children, which documents the project. But it's not ended, the project, it's actually still going on. Even so, they started a new project now in Brazil, and that's somewhat different, and you'll hear more about that today as well. Apart from being absolute top researchers with complementary expertise, these 3 men are good friends, as you must be to survive such endeavors, I can trust. Without further ado, I give the floor to the first of the 3 presenters now, Chuck Nelson. Chuck, yours is the floor.
Thank you very much. It's a pleasure to be here. Let me get my slides up. Just give me 1 second. Okay. Can everyone see my slides? Yes. Could someone?
Yes.
Okay. Thank you. All right. So my job is to provide the background to what led to the Bucharest Early Intervention Project, and then I'm going to turn things over to my colleagues. Nathan Fox will probably begin by summarizing some of the key findings, and then Charlie Zena will move to the project that we have been trying to launch in Brazil for some time now. So let me begin with the hazard of raising children in institutions and the benefit foster care, or in families rather, which I think all of you probably appreciate a great deal. When we designed the study in roughly the year 2000, we had three aims. One was to examine the effects of institutionalization on brain and behavioral development in young children. A second was to determine if these effects could be remediated through an intervention, in our case, high-quality foster care. And the third was to improve the welfare of children in Romania by establishing foster care as an alternative to institutional care. So let's now ask why institutional rearing might be bad for the brain. And as some of you know, the figures of the number of children worldwide who are in institutions vary widely, but one estimate is that it could be 150 million. We know that more than 10 million have been orphaned by COVID-19. There may be 2 to 8 million currently living in institutions. So this is a big public health issue. One is that children in institutions have a very regimented daily schedule. All children are exposed to the same things at the same time of day, but the same over and over again. The care is non-individualized. It's group care. So in any given day, there could be several caregivers who take care of a child, and that could change day by day. That there's often sensory, social, emotional, cognitive, and linguistic deprivation, the very input that children need to grow and develop. There's often no response to distress. Children cry and no one pays attention to them. There can be unchecked aggression. You see this particularly as children get a little older. There's a lack of psychological investment by the caregivers. Often the caregivers, this is a job, this is not their children. They don't really invest in the caregivers. And there's a very high ratio of kids to caregivers. So there may be a dozen children to be taken care of by one caregiver. And then there are rotating shifts of caregivers, the morning shift, the afternoon, the evening, the night shift, and so on. We have known for basically 100 years that children reared in institutions are at a very high risk for developing a variety of cognitive, social, and emotional behavioral problems. This includes disturbances in social relatedness and attachment, externalizing behavior problems, inattention hyperactivity or ADHD, deficits in IQ and executive functions. Executive functions are these higher order cognitive functions like planning or cognitive flexibility, and a syndrome that mimics autism, and finally, growth stunting. So why do we do this work in Romania? Well, first, by 2000, or 1999 or through 2000, there were still tens of thousands of children living in orphanages throughout the country. Most had been abandoned at birth, and it had all been part of the Ceausescu regime a decade or earlier. It gave us the opportunity to study the importance of early experience in young children. We know that experience is the engine that drives development. So if experiences are lacking after birth, the brain is deprived of experiences and it really doesn't know what to do. So we were invited into the country by the then Minister of Child Protection to do this study, thinking that science would inform policy. There was an interest in developing new policies for intervening in the lives of abandoned children. At the time we started, the country believed, policymakers believed, that the best alternative for an abandoned child was to put them in an institution. So the government viewed institutional care as the intervention for child abandonment. So we wanted to compare institutional care compared to foster care. So this, as we heard a moment ago, was the first ever randomized controlled trial of foster care as an alternative to for the deprivation associated with institutionalization. Dana Johnson, a former colleague of mine at the University of Minnesota, pediatrician, he and a pediatric nurse practitioner screened more than 180 children using a pediatric and neuro exam to rule out children that had obvious neurological or genetic problems. And of those more than 180, 136 were considered to be healthy. That is, no frank neurological or genetic problem. We did an extensive baseline assessment when the children were between 6 and 31 months. The mean age was around 20 months. And following the baseline assessment, we randomly assigned roughly half of the children to continued institutional care or care as usual, and the other half were randomly assigned to a foster care intervention, which I'll talk about in just a moment. And we also recruited a sample of 72 never institutionalized children that served as sort of an age and gender match comparison sample. So we basically did a baseline assessment of these 72 never institutionalized children, the 136 institutionalized children. The randomization took place, at which point we then started to follow up the children. We saw them again at 9, 18, 30, 42 months, then again at 54 months, and then again at 8 years of age, 12 years of age, 16 years of age. And at the current time, we're actually seeing the children again when they're roughly 21 or 22 years of age. So here's the design. Kids come into the institutional group, then random assignment to care as usual or foster care, and then we have the never institutionalized group continuing to follow. There was a great deal of discussion in the beginning of the study of what domains we should study. The three of us come from different backgrounds, and so we all had our favorites. This, in the end, was the list of domains: physical development, language, social emotional development. We characterized the caregiving environment. We looked at cognitive development. We looked at attachment. We looked at temperament. We looked at brain function like EEG. We looked at brain anatomy using MRI. We did genetics and epigenetics on the sample. And perhaps very importantly, we looked at psychopathology, given the long history in the literature that children reared in institutions have a very high rate of having mental health challenges. A lot of ethical considerations. We needed informed consent, of course, from the 3 universities in the US, local authorities in Bucharest, parents, caregivers, and guardians. The reason we could do randomization is that in the studies to date, where children who had been adopted out of institutions were studied, the concern has always been whether we could draw a causal inference. That is, there's a risk of sample bias, who gets to be adopted and who doesn't. So randomization would take care of that issue. In Romania, there was a policy debate about what is the best intervention for abandoned children. And if we hadn't done the study, all the children would continue to live in institutions. And as you'll hear at the end, the big policy changes that occurred in Romania since the study started are in part attributable to the science of this study. There was no more than minimal risk to participating. We didn't use measures that hadn't been used before throughout the world. We could not adopt a stop rule when you do a clinical trial and you start to see efficacy of the intervention. Think of the development of vaccines for COVID. You either give everyone the intervention or you stop the trial, but we couldn't do that. We didn't have enough intervention to go around. We only had 58 families. And so if we had stopped the study, all the children we placed in foster care would go back to the institution. And in addition, we just could not find more intervention to go around, so to speak. And we had a policy of non-interference. We assumed at the outset of the study that the government authorities would periodically go to an institution and take a child and reunite them with their biological parent or place them in government foster care. We had no say in this. That was something the government did. We provided outcome data to the government as soon as it became available. So as we started to see the return on our investment in the study, we shared that with the government. The foster care intervention was very high quality. Families received a monthly stipend equivalent to the per capita income in Romania at the time. They were closely monitored. Our social workers visited the families about every 10 days. They met with the team in the US, mostly the team at Tulane University with Charlie, every 7 days to troubleshoot problems that families were having, and we did all we could to help those families. We provided all material support. There was a 24-hour on-call pediatrician. Romania law required one parent to stay at home with the child. All the families were licensed. And the way to think of this is this was, much better foster care than typically is rolled out in countries. It was a child-centered model of foster care. It was orchestrated around the needs of the child for a stable, consistent, emotionally available caregiver. I want to emphasize this, that the goal was to build relationships and provide good caregiving. It wasn't to improve IQ or cognitive development, but actually it did, as you'll hear shortly. The foster care parents became emotionally invested in the child and advocates for the child as though the child was her own. The social worker supports and monitors and intervenes when the foster parents are needed with frequent contact. So an example might be a family takes a child in and they have difficulties getting the child to eat or getting the child to bathe or go to sleep. We tried to do all we could to help those children, hence the weekly consults with the team in New Orleans. In the analysis we've done, we have primarily focused on intent to treat. This is standard in randomized controlled trials. It basically treats the data as though the children are followed based on their original group assignment, not what treatment they received. So let me try that again. We originally randomly assigned 68 children in foster care, 68 to care as usual. Over the course of the study, the vast majority of the kids randomly assigned to care as usual actually left the institution by government decision. But we analyzed the data based on which group they were assigned to at the outset. Alternative approaches, as treated analysis, it compares based on treatment received at the end of the trial. I'm almost done, Mariana. And adheres only analysis, compares only subjects who did not deviate from the assigned treatment. You will hear in a moment that the one place we deviated from random assignment, from intent to treat rather, is we looked at stability of foster care as a factor in outcome. Conclusions and findings. So briefly, neglect and deprivation dramatically increases the risk for reduced brain power, lower IQ, poor executive functions, and serious psychopathology. The longer children are in institutional care, the greater the probability of harm. Recovery is enhanced by placement into foster families, foster placement as early as possible. That's the timing effect you've heard us talk about, the stability of placement over time, and higher quality of care. And so at this point, let me now turn things over to my new two colleagues who will talk first about the findings from BEIP and then about the new project in Brazil. Thank you. So I think Nathan is next.
Yeah, Nathan, yours is the floor. You can share your screen. Excellent. Yeah. You're still muted?
Yep, now I'm unmuted, right? Okay. Great. Can you all see the screen?
Perfect.
Great. So hello, everyone. One of the things about working with my two colleagues is that there's never a dull moment over the course of these 22 plus years. I'm actually not going to be talking about the findings from the Bucharest study this morning. I believe that we have sent our bibliography to you, which has a list of all of the papers that we have published on the study. And as Chuck mentioned, we are currently collecting data on the sample when they are between the ages of 21 to 22. Rather, what I'm going to do this afternoon, is introduce to you a new study that the three of us, along with colleagues in São Paulo, Brazil, have launched. And we've called that study Early Institutionalization Intervention Project. And let me tell you a little bit about it. First, let me, okay. So we are focusing this project in Brazil. As many of you know, Brazil is the largest country in South America and Latin America. And we are focused in São Paulo. Now, the state of São Paulo has over 25 million people. The city of São Paulo, half of them living within the city of São Paulo. It is a really amazing city, multicultural and ethnically diverse, due to more than a century of mass immigration. In Brazil, traditionally, there has been a heavy reliance on institutional care for abandoned or abandoned children or children that through child protection are removed from families. In 1990, there was a statute which said that all children have a right to grow up in a family. And so over the next 20-some years, there was a gradual closing of large institutions. However, when we started the project, or started visiting Sao Paulo some 5 years ago, there was still, and still exists today, a system of what are called abrigos, or shelters. Originally, those shelters had about 30 children. Now they are down to about 15 children per abrigo. Originally and initially, they were same age. So that is, the abrigos had only infants, but recently they've changed that so that it's mixed ages. Children are generally removed because of maltreatment, the majority for neglect related to substance use, and some may be targeted for early adoption. Indeed, in Brazil, there's a great demand to adopt infants and a long waiting list. But there are complications in terms of the process by which children can be adopted. And indeed, this has been a challenge for us in terms of the study that I'm going to be telling you about. The way that children are assigned to these abrigos is generally through 3 sources: hospitals, through the police, or through what's called a child or child's council. And children or infants or children are referred to something called a childhood and youth court. There are psychologists and social workers who are involved in making a determination for that infant or young child. Ultimately, though, there is a family court judge who makes the assignment of that infant or young child to an abrigo. So as has been mentioned, Chuck Nelson, Charlie Zena, and I began the study, and we are collaborating with Edson Amaro and the Pensy Institute at the University of Sao Paulo. We have a research team there. Julie Staples Watson is our project coordinator here in the United States. And we have 3 staff in Sao Paulo, Laura, Nara, and Stella, and they are involved in the data collection for this study. Here's the design. And I'll say a little bit more about the differences between this design and the Bucharest project in a moment. I don't know if you can see my cursor or not, but the idea is, again, to have a randomized controlled trial. This was actually an important issue for us. And in one of our early visits to Sao Paulo, we met with those family court judges and asked them whether they would be willing to participate in an RCT, in a randomized controlled trial. And to our amazement and delight, they said that they would. So we're going to identify 200 infants who are generally referred by these family court judges, but they are going to randomize those infants. 100 are going to go to the abrigo or to the shelter, and 100 we are going to place into foster care. We're also recruiting a community comparison of 100 children who are in childcare. Those 200 infants that we've randomized to either the abrigo or to foster care, they're going to undergo, actually, their caregivers, their foster caregivers or the shelter caregivers are going to undergo an intervention called the AVI, the AVI. And I believe that Charlie is going to say a little bit more about this. It's an attachment-based intervention to develop heightened behaviors of sensitivity and responsivity on the part of the caregiver. And then we are going to follow these infants, the ones that were assigned to the shelter or the ones that were assigned to foster care at both 24 months and 36 months. So as I mentioned, one other thing to mention, which is important, is that one of the things that we will be doing towards the end of this project is we're going to be doing an economic analysis, cost benefit for the project. Oops, sorry. So the domains that we are going to assess are quite similar to the domains that Chuck already outlined for you that were done in the Bucharest project. We're going to be assessing attachment, cognitive functioning, socio and emotional behavior. We'll be measuring physical growth, height, weight, and head circumference. We'll be assessing brain activity using EEG. We'll be assessing emotional and behavior problems of the infant and young child using caregiver ratings. And we'll be assessing competence of the infant and young child also via caregiving ratings. We are partnering with a program in São Paulo that is called Santa Fe, and Gloria Luz Lanz is the executive director there. And she and her group are involved with us in terms of identifying families, foster care parents. And they are going to be partnering with us in terms of training those foster parents, and then obviously in terms of the follow-up of those foster parents and foster families over the course of the study. Like the Bucharest project, there are ethical dimensions to this project, given the vulnerability of the population. We have an agreement, as I mentioned, by the Judiciary and Social Services that the study would address an important problem in São Paulo and provide data to inform policy decisions. There's obviously a risk-benefit ratio. We believe the risks are minimal. The activities and procedures are similar to hundreds of other studies, including those in the Bucharest project. And there are benefits from the intervention, the AVI intervention that we are doing. And one important thing to note is that both arms of the clinical trial, both the caregivers who are at the shelter and the caregivers who are in foster care, are going to benefit from the AVI intervention. Like the Bucharest project, we have a policy of non-interference. All the placements are going to be ordered by the family court judge, as I mentioned, and the study team is not going to be involved in that. There's randomization, which will allow us to the strongest type of evidence and social value of that. And there's oversight by both university institutional review boards and the PENSI Institute Ethics Committee, as well as the National Brazilian Federal Ethics Committee. So I mentioned that I would discuss the differences between the BEIP project and the one that we're starting in Sao Paulo. The first is that one of the things that we've heard as we presented findings from the Bucharest project is that, well, the condition of institutions in Romania as a result of the Ceausescu era were particularly harsh, and there's really no applicability to the condition of institutions in other parts of the world. So for that reason, we're on another continent and with a very different child protection system. The other issue that we've often heard about the Bucharest project is that the condition of the institutions in Bucharest was particularly poor. And so the answer to that is yes, but the institutions in Brazil, and particularly in Sao Paulo, they're still institutions, and there are 15 children with better caregiver to child ratios, but as we like to say, they're still institutions. In the Bucharest project, we had no prenatal data that we could collect. The infants that were in the Bucharest project were already abandoned, and we had no information about prenatal history. In this instance, we have an opportunity to have more consistent prenatal and pre-placement history of the infant circumstances. Unlike the intervention that Chuck told you about for Bucharest, where we had augmented foster care, but not institutional care, in the Sao Paulo study, both arms will be augmented in the RCT. One of the things that Chuck may have mentioned is that we started the Bucharest project somewhat late in terms of the infant or young child's life. And now in the Sao Paulo study, instead of the mean age of initiation of 22 months, we are hoping that the initiation will be likely less than 1 year of age, with the idea that the earlier we can intervene, the better. And one of the other comments about the Bucharest study is that our comparison group was somewhat more advantaged, in the Sao Paulo study, we will have a less advantaged comparison group. And finally, as I mentioned just a few minutes ago, in the Bucharest project, we had no economic analysis, and we will have a cost-benefit comparison of the two interventions in the Sao Paulo project. So in summary, we hope to provide scientific evidence about the best and most economical form of care for orphans and vulnerable children. We want to persuade governments and donors to make more evidence-informed policies and investments to improve the lives of children currently in institutional care. As Chuck may have mentioned, there are still millions of children around the world who are living in institutional care, starting very early in their lives. And our goal is to attempt to identify forms of care for them early in their lives in order to benefit their lives. And with that, I will thank you.
Thank you. Thank you, Nathan.
To exit. Yep.
You can stop sharing your screen.
I did.
Great. And we'll continue with Charlie. Yeah.
Thank you. Okay, everyone can hear okay? Sounds good. Okay, so I'm just going to briefly describe a little bit more about the attachment video feedback intervention, or AVI, or what some people call AVI. We're very excited about this. because this will be the first time that an evidence-based intervention has been embedded into these two very different caregiving settings. And by augmenting both settings, we'll be able to compare whether or not the AVI intervention has a differential impact. It's a dyadically focused intervention. So it's a coaching intervention with a caregiver, but it's specific to a particular child that caregiver is working with, and it's designed around characteristics of that child and that child's relationship with the caregiver. So we'll have children randomized to shelters, children randomized to families. After baseline assessment, they will get this 8-session intervention, which is administered over a period of 2 to 3 months, and then we'll be assessing outcomes at regular intervals. Chantal Cyr and George Tarabulsi, who've been very involved with this intervention for a number of years, were kind enough to go to Brazil and train our group there, and have continued to provide consultation to us. So we just want to acknowledge their help. The intervention team is at an NGO in São Paulo called Fazendo Historia. There's a wonderful team of interveners shown here. Melissa Middleton is a faculty member at Tulane in New Orleans who works with me and has many years of experience dealing with children in foster care. And she's providing regular consultation and support to the intervention team in São Paulo. So, as I said, it's an 8-session intervention. It's administered in the setting where the child is living, whether that's a shelter or a foster home. It specifically targets parental sensitivity and child attachment, and encompasses both verbal and nonverbal interactions with the child. So responding to the child's distress and promoting and supporting exploration when the child is not distressed. The sessions last about 90 minutes. The first session, called Visit Zero, is more or less an assessment session to develop specific hypotheses about what would be helpful to this dyad to promote more sensitive caregiving and more secure attachment in the child. And then each of the following 7 sessions are designed to address the specific hypotheses that were generated in the assessment. So the targets are, similar to the targets of these types of interventions in other settings: caregiver sensitivity, proximity to the child, physical proximity to the child, being responsive to the child's expressed needs, and engaging in socially reciprocal interactions with the child to enhance the relationship. So the way the sessions begin is initially with a 10 to 15 minute sort of review of what's happened typically, and then 20-minute discussion. The intervener selects a topic for the dyad and focuses on the caregiver's understanding of the child's needs and developing alternative frames for that, and then an activity for them to engage in after that. Then, having done that activity, there's a 20-minute video feedback review. So what's just been filmed gets reviewed with the caregiver and discusses the caregiver's feelings and observations of themselves and of the child, and basically is an effort to enhance the capacity of the caregivers and foster parents to engage in reflective functioning. And then there's a 10 to 15-minute wrap-up, highlighting progress, encouraging similar activities. This is pretty much a strengths-based intervention, focusing on the positive as much as possible. There have been to date 4 randomized controlled trials of this intervention that have been published. There are at least 4 more that are underway, but they've basically shown in these randomized controlled trials the ability to have an impact on caregiver sensitivity during interactions and to have an impact on the child's secure attachment or behaviors that are believed to reflect secure attachment. So this is kind of the evidence base for the intervention. Obviously, this is the first time that this intervention has ever been administered in an institutional setting. And so that will present some unique challenges. And fortunately, we've been able to do some pilot work that has enabled us to get a feel for that. For example, the institutional caregivers say, well, I've got all these things I have to do. And so helping them understand that they can engage in these activities with children, even at times when they are taking care of their basic needs, like changing diapers or feeding or whatever. So it's been an interesting experience to see how this has been accepted in these Abrigo settings. And just to review what I just said, we've completed pilot intervention work with 10 foster care children and 2 children in institutions. We had another 6 underway, and the city of São Paulo decided to close the institution where we were doing this work and to refer the kids out to other institutions. It turned out that this was a baby-only institution, and the momentum in São Paulo is to move towards having kids only in mixed-age institutions. And so this was part of their planned transformation of the shelter system. We have a few cases underway, but we've also had our first child randomized to foster care. We're giving that child time to settle into their new home, and then we will conduct the baseline assessments and then begin the intervention shortly after that. Large number of collaborators and funders involved in the study, and we have appreciated all of them and look forward to continued work with them.
Thank you so much, Charlie, Chuck, and Nathan, for this great presentation. Very informative for our group. There's some questions been coming in. The first is on the BEIP, and I'll phrase it here. And the question is, have you considered asking the now young adults, participants, that what they think of their participation in this study? And having been randomized, it will be interesting to hear their voices, or is that perhaps currently going on in this new round of data collection? Could any one of you reflect on that question?
Well, I can begin to reflect. The answer is yes. We are, in fact, have designed an interview that we are going to administer. I don't think we'll be able to administer to all of the participants, but we are planning on administering the interview to a select group of both the adults who were randomized to the care as usual and a group of adults who were randomized to foster care, and discuss just those issues. That interview has just recently been approved by the scientific committee at Boston Children's Hospital, and it's now wending its way through the IRB there at Boston Children's, and then through the Bucharest University before we can commence that work. I don't know, Charlie, do you want to say anything more about that?
Well, we're not sure exactly how many of these young adults we will be able to interview and collaborative people, but we're hoping it's what we're hoping to do is have a relatively small number with very in-depth stories of their lives, essentially. In terms of, I don't think we've asked the participants directly what participating in the study has meant, but after some initial drop-off, our attrition rates have been very small, and we find that study participants will often stop by the lab simply to chat, or they've established relationships with the staff there. And I think obviously their willingness to participate through all these waves of data collection speaks something to their commitment to the project.
Okay, thank you. I'll move on to one of the further questions, which is about the Brazil project. And one of the questions is, given that your comparison group is less advantaged as well, did you consider offering home visiting sessions to that group also? Or perhaps in another study arm?
We considered many things. And the realities of budgets and funding limitations have restricted our focus to what we have now. We originally had an initial historic control of just studying children in institutions in Brazil now that we then compare to those who received the AVI intervention later. But because of struggles with funding, we've had to trim back.
Thank you. One of the other questions is about the choice of the intervention. There are several different possibilities available for improving parental caregiving or caregiver sensitivity. How did you choose this intervention?
So it's true. This is very similar to, at least in philosophy, I think, to attachment and biobehavioral catch-up, and also to BEIP, which, Marion, you may have heard of that. I'm not sure. And, you know, it was sort of a combination of figuring out what's feasible, what's available in Portuguese, what can be translated easily. And eventually we wound up with selecting this AVI intervention. And I have to say, we were, of course, affected by the fact that it had been demonstrated to be effective in enhancing caregiving sensitivity and attachment security in children who've experienced abuse and neglect, very young children.
Yeah, thank you. Yeah, we're very happy that the BEIP-PSD has recently been considered evidence-based by HOMVI. So that's a good thing, but unfortunately it was not available in Portuguese. We hope that it will be in the future. There's also a question about Africa, the African continent, particularly sub-Saharan Africa. And I almost do not dare you to ask this question, but do you have a future plan for such a study on the African continent?
We've been talking about what to do when we each are 100, and that seems like an interesting thing to undertake. Yes.
Interestingly, and slightly more seriously, when we were thinking about the project in Brazil, and we were working with another group, we had a list of other countries that we thought we could roll a new study out. Sub-Saharan Africa, of course, was high on the list, but for a host of practical and logistics reasons, it just didn't make the cut, only because it would be so challenging to do that. And having just come back from Cape Town, I can tell you that commuting to Romania is easier than commuting to South Africa, for example.
So too bad for the continent, which then has to wait a bit longer, but I hope you'll reach the 100 and that it will be on your bucket list. One of the attendants wrote, in Brazilian children's law, placement in institutional care can only be for a maximum of 18 months. How have you managed to factor this into the study?
Well, I'll let Charlie may know, or Chuck may know more, but my understanding is that there is an attempt to both an attempt for reunification as well as for adoption. But if neither of those work out, which is the case for many of the infants in the abrigos, there's nowhere for them to go except to remain in the abrigo past the 18-month.
Yeah, I mean, the way this first came to our attention is when we were visiting these abrigos, we saw a lot of older children, and then they'd tell us about this law, and we said, well, how come there are all these 5- and 6-year-olds there? And they said, well, that's because that's the law, but the reality is there's often not a place for these kids to go.
Yeah, so that's perhaps related to the next question. If you were not conducting this study, would all the children end up in abrigos by default?
Pretty much. There are a couple of NGOs that sponsor foster care. The largest has 35 foster parents in a city of 12.5 million people. So obviously the availability of foster care is extraordinarily limited at this time, much like it was in Romania when we started there. And so really there's no other option for the vast, vast majority of children.
Yeah. Just for clarity, on one of your slides, it showed that you include children under 24 months of age. That means that the older children could perhaps indirectly profit from enhanced caregivers, but are not randomized?
You mean older than 24 months?
Older than 24 months?
Well,
they're not randomized into foster care, or?
No, if they're older than 24 months, they wouldn't be in the study.
Yeah, clear. Then there's one technical question, or practical perhaps, but the question is, how did you decide on the sample size of 200? Was there a power calculation, or was this what was feasible? What were the thoughts of starting with 2 times 100?
Yes, it was based on power calculations and the anticipation of attrition over time and the usual things.
One question is, the ethics and design of this research is, of course, very complex. What are your thoughts on the size of the abrigos, being institutions for 15 children, which is somewhat smaller in size than the majority of institutions in other countries? What do you think of that size? How may that affect your findings and their applicability elsewhere?
Well, there's a little bit of research, not a lot, indicating that in institutional settings, the more the setting resembles a family, the better for the children. And so 15 is better than 50, is better than 500. That's what I would anticipate. And that in a setting with a smaller number of children and with better child to caregiver ratios, that one would expect that the children in the abrigos would be advantaged compared to children in much larger institutions with much less optimal child to caregiver ratios. So it's a challenge to the comparison. On the other hand, the other difference that Nathan and Chuck talked about is that because we're getting in younger, when the children are much younger and possibly will not have any exposure to institutional care, whereas in Romania, the kids had an average of almost 2 years of institutional exposure. We're hoping that will make a difference.
Thank you. And the abrigos, are they usually run by governments, or are there any that are run by religious institutions?
Yeah, I think they're primarily run by the government. I think there are some that get licensed with religious affiliations as well.
Let me see, you do a wonderful job in answering so many questions, whether I see more on my screen. Age group, we've had that. I think we were more or less covering all. You've covered all the questions, and that's really impressive. Then I think my task is then just to thank you. Big thanks to you as our presenters, and giving feedback to our questions that are so important for us as a working group. We look forward to hearing more about the Brazil project and also on the follow-up measures doing adulthood in the BEIP. And for all who are attending, we will sending an email with a link to the meeting recording, the slides, and the other resources that were mentioned during the presentation. And for today, it only remains for me to wish you a very good day. And thank you all for being here. Thank you.
Thank you very much.
Thank you for having us.
Okay.
Thank you.
Everybody.